Welcome to the Johns Hopkins Center for Fetal Therapy webinar series. Today we will be speaking about fetal anemia and recent developments in the evaluation and management of it. The featured speakers today are Drs. Amit Bashat and Jenna Miller from the Johns Hopkins Center for Fetal Therapy. Also joining us is Bethany Weathersby from the Allo Hope Foundation.
Thank you. Can everybody see my screen?
Yes.
Okay, great. All right, so I wanted to just set the stage and talk a little bit about the different forms of fetal anemia. First of all, fetal red cell production starts very early in pregnancy, and the early fetal hemoglobin is actually not comparable to what we have later on as a fetus. And sort of after 12 weeks, there's an increasing transition to fetal hemoglobin in a small proportion of hemoglobin A. Important to know that red cell production is in the same control as in, after birth under erythropoiesis, and early on in fetal life takes place in the bone marrow and in other tissues such as the liver and spleen, which can be reactivated when there is fetal stress or fetal anemia at any point after that. If that doesn't happen, then at some point, the fetal red cell production basically just continues in the bone marrow, where it also continues in adult life. So just important to recognize that the potential for producing increased red cells is particularly good before 28 weeks and gets sort of later on a little bit less elaborated. Fetal anemia is basically a low fetal hemoglobin content, and it's classified in two principal approaches. One is the hemoglobin deficit from the expected reference range, as you see on the left-hand side, or multiples of the median when you plot these over for a normal reference population. Irrespective of the cutoff, if you have a hemoglobin difference more than 7 grams per deciliter from the mean, or have less than 0.55 MOMs, multiples of the median, that's when the risk for fetal high drops increases, and that's what ultimately defines severe anemia. Now, there are different types of fetal anemias, and it's important to understand how they cause fetal anemia and how the associated presentations may be. Dr. Miller is going to talk about the antibody-mediated red cell destructions, which produces a hemolytic anemia. Then you can have anemia, which is secondary to viral infection, which can either damage the red cell precursors or affect the lifespan of red cells. So you can get an aplastic or a hemolytic anemia, depending on the kind of infection. Then you can have anemia due to abnormal formation of red cells or abnormal formation of hemoglobin. So that can affect the stability of the red cells. So you can have a hemolytic anemia where the red cells just spontaneously fragment, or you can have an aplastic anemia where red cells are not being formed at the bone marrow level. And the hemoglobinopathy can basically give you a functional anemia where, although the hemoglobin content in a red cell may be normal, it doesn't have the normal carrier functions, and therefore, the oxygen carrying capacity of blood is not as it should be. Fetal maternal hemorrhage occurs when there's red cell loss over the placenta, sometimes spontaneous and sometimes caused by trauma, and bleeding risk associated with monochorionic placentation is typically due to either a single twin demise, where you have one baby having acute blood loss to the co-twin, or you're having vessel connections that promote disproportional sharing of red cells from a donor baby to a recipient baby. And all of these can give rise to anemia in one of the babies. And then finally, you can have anemias that are due to red cell destruction and an abnormal circulation in things such as tumors. So most commonly in placental tumors, or sacrococcygeal teratomas. And these findings are often associated with a hyperdynamic circulation, which actually accelerates the speed with which red cells are pushed into the microcirculation. And basically, the immune anemias are the ones that have to do with antibody production against red cells, and the non-immune anemias encompass all those. Now, how do we diagnose in the anemia in the fetus? This is principally done by ultrasound, and the primary tool is Doppler ultrasound. It was long recognized that when there is fetal anemia, the speed of blood flow increases, and the early studies looked at the thoracic aortic mean velocity, and then in the mid-90s, Giancarlo Mari's group established the middle cerebral artery peak systolic velocity as a reliable reflection of fetal hemoglobin content, and the splenic artery is reacting similarly. So we have at least 3 vascular systems where we have good reference ranges that correlate with fetal anemia. It's important that there's other factors that increase the blood flow velocity, best documented for the MCA, where we know that CO2 retention and a low pH can lead to increased peak systolic velocities, as you might see in fetal growth restriction. And it's also extremely important that all of these measurements are really taken at fetal quiescence, because high fetal activity also affects the peak systolic velocity. As a rule of thumb for the MCA and for the splenic, the peak systolic velocity should not be more than twice the gestational age in centimeters per second. For the thoracic aorta, we use the mean velocity, which most people are not that familiar with, and we rarely employ that vessel. What has been demonstrated in some landmark studies really is that there's a very high correlation with severe fetal anemia with an elevated MCA over 1.5 multiples of the median. You have a similar predictive capacity for the splenic artery as well, but the MCA is certainly the primary tool, and both vessels illustrate that that prediction is particularly good in the untreated fetus, so the first time you suspect fetal anemia. Once babies get transfused, that correlation is lost to a certain degree, and the prediction of the thoracic aorta is certainly not as accurate, and that makes basically the MCA the primary screening tool for fetal anemia in a non-transfused baby. Now, there are several other ultrasound findings for fetal anemia that we need to be aware of. Skin edema, fetal hydrops, and hydrops and swelling of the placenta. Then you can have fetal anemias that are associated with viral infections that might predispose to thrombocytopenia, spontaneous hemorrhagic risk, and also calcifications or echogenic areas within the fetal brain. So beyond the MCA, a really detailed examination of the fetus is required. Fetal anemia can affect the cardiac function, so we can see problems such as cardiomegaly, valvular regurgitation, and the severity of anemia and the ability to tolerate treatments is, and fetal transfusions goes down once you have hydropic babies. And then there are several abdominal findings such as echogenicities and ascites, and also splenomegaly, which is due to extramedullary hematopoiesis. So there are several markers on ultrasound that point us to the severity or maybe the type of anemia. Now, other things to look at is obviously, is there a physical cause, such as a chorangioma, a sacrococcygeal teratoma, or here a cavernous liver arteriovenous malformation. All of these cases were associated with symptomatic severe fetal anemia. Now, alloimmunization, and Dr. Miller is going to talk more about that, is basically when there is an incompatibility between the maternal and the fetal blood type, which after a period of sensitization leads to the production of antibodies to fetal red cells. If the fetus in the current pregnancy has non-compatible red cell antigens, there is a risk for fetal hemolytic anemia. And among the numerous different blood types, it's the Rh, the Cal, little c, and that's the high risk conditions for fetal anemia, and big C, E, Duffy, and then KIT and the MNS system less frequently. But so the high risk anemia antibodies are really the Rh and the Cal system. And these can lead to hemolytic anemia in the fetus. Now, part of prenatal care, maternal risk stratification is our obligation as obstetric providers, and getting the Rh type and following the antibody type and titer is important because it identifies the fetus at risk. Fetal risk stratification is also important because it is really only the fetus that is not compatible with the maternal blood type that's at risk for Rh disease. And that can be done if the paternity is certain by getting the maternal and the paternal blood genotypes. And now what has transformed the ability is also to get the fetal blood genotype on cell-free DNA and next generation testing. And that has sort of obviated really the need for an amnio to get the fetal RBC type. And nowadays, first trimester fetal cell-free fetal DNA has a very, very high sensitivity and specificity for Rh and also for Cal and Duffy. Important to recognize false negatives can exist if the blood draw is done too early, or if there's a very low fetal fraction, and there are differences between the labs and the sensitivity. And we'll sort of come back to that a little bit later. But having access to cell-free fetal DNA potentially prevents, a large amount of unnecessary ultrasound or blood surveillance. Now, once you suspect fetal anemia, it's important to take maternal history, do the maternal blood testing, a detailed fetal ultrasound, and then you do the invasive testing. The laboratory studies that we obtain when we do fetal blood sampling tell us several aspects about the fetal anemia that are important of making a decision what the likely cause might be if we don't have a firm indication based on the history. So the Kleyer-Oettger tells us the percentage of fetal cells and the purity in a sample. A direct Coombs test tells us about antibody binding on red cells. The blood smear tells us about abnormal red cell shapes, which can be due to abnormal red cell production or destruction. The hemoglobin electrophoresis tells us about the distribution of hemoglobin types and if that's a contributor to the fetal anemia. So we target our testing based on what we think the cause of the anemia might be. And fetal blood sampling and transfusion is basically the, how we treat. We have different access methods: intrahepatic umbilical vein, the placental cord insertion, the free loop of the cord, and intraperitoneal in early transfusions where the vascular access might be challenging, and then under extreme circumstances, intracardiac access. Of these, the intravascular access has higher survival rates than intraperitoneal, and that's basically because intraperitoneal is typically done before 20 weeks, and babies that present with that early anemia by default have a more severe form of anemia. And in addition, there's cardiovascular risk from, putting too much fluid into the abdomen. There are other specialized techniques that we use in twin anemia polycythemia sequence, where we do a fetal blood transfusion of the donor, but we actually do a partial exchange in the recipient, which means the recipient twin who might have a hemoglobin of 20 or 22, we take actually physically blood off and dilute that with saline to bring the hemoglobin to a more normal level. So parvovirus transfusions, the frequency is based on disease severity. So with Rh disease and with TAPS, you have to do serial transfusions, as transfused red cells only have a certain lifespan. In parvovirus, we oftentimes get by with 1 or 2 transfusions, because as the bone marrow recovers, the baby sort of makes its own red cells again. And the overall outcomes really depend on, how early you get to treat and how severe the treatment is. Fetal maternal hemorrhage is a difficult condition to treat well, because the recurrence risk is really very difficult to anticipate. And so you need to just follow these patients with serial MCAs, and you have to have a high index of suspicion for rebleed, even if there's abnormalities in fetal testing. And these can point to severe acute anemia. Here, a case that presented actually with an abnormal biophysical primarily, and had significant transplacental fetal maternal hemorrhage, and associated with the need to replenish red cells, you can actually get secondary thrombocytopenia. So the cardiovascular impacts of fetal maternal hemorrhage are often associated with secondary bleeding problems, like in this baby that had an intraventricular hemorrhage. The dyserythropoietic anemias and hemoglobinopathies require a fetal blood smear and often genetic testing. And here the blood transfusions are often linked to tide the baby over to receive bone marrow transplantations after delivery. And here you can sort of use prenatal HLA typing. And these anemias can present at different stages of fetal disease. Most often we see these actually presenting with high drops. Tumor-related anemias are basically due to red cell destruction, and they're often associated with complex hematologic features such as platelet consumption coagulopathy, and you need to be prepared in these cases not only to give red cells but also platelets. So just looking at the frequency of and the management approach for the different anemias at a fetal therapy center. So in terms of the anemias, we basically target our treatment and how we transfuse and how we test to the underlying pathology. Most of the anemias that we see are basically due to non-immune, due to immune fetal anemia. So these are Rh, Cal, and Duffy. And but we are also more frequently starting to see anemias that relate to monochorionic twin complications, sudden single twin demise. With particularly in the high drops cases, we see abnormalities in red cell synthesis, and fetal infection, particularly this and last year, we've seen a lot of parvoviruses, and because we see a fair amount of cases with placental tumors, we also see a fair amount of angiopathic anemias. So in conclusion, alloimmune is still the most frequent cause of fetal anemia, and there is a very well-established prenatal care standard and threshold that helps us to identify babies when they require initiation of fetal blood transfusions. And in non-immune fetal anemias, it's the underlying pathology that determines the management goals and strategy. Thank you very much. So I'm just gonna hand over now, I think, to, is it you, Gina, now, or is it Beth?
Nope. Next, we welcome Bethany, and I'll just pass it along to her, Weathersby. We're really grateful to have her today with us from the Allo Hope Foundation, representing the patient perspective for parents that undergo fetal blood sampling, transfusion, and the experience of Rh disease. So Bethany, I'll hand it off to you. Thank you.
Thank you. Let me screen share. Let me see. All right, so thank you so much. It's an honor to be here. I'm Bethany Weathersby, and I'm the founder and executive director of the Allohope Foundation, a nonprofit organization that supports providers and patients managing alloimmunization and hemolytic disease of the fetus and newborn, HDFN. Even more importantly, I'm an alloimmunized mother myself. And it's not going to the next slide. Let me see.
If you just click on the slide and then it should advance.
Let's see. There we go. Did it go to the next slide for you guys?
Yes.
Yes.
Okay. So yes, I'm an alloimmunized mother, and 4 of my pregnancies have been severely affected by HDFN. Fetal anemia has permanently altered my life and reshaped our family, as you can see here. Before my diagnosis in 2013, I had never even heard of fetal anemia, never had a thought about it. But everything changed with my diagnosis. And suddenly fetal anemia became my greatest fear. And now, all these years later, it's at the center of my life's work. So after 2 healthy pregnancies, I tested positive for anti-kel antibodies during my 3rd pregnancy. My titer was incredibly high, 1,024. And you know that that's very alarming, especially for kel antibodies. So I was referred to a large teaching hospital with a team of 11 MFMs, but my concerns about my baby being affected by my antibodies were largely dismissed. I was told my disease would probably be mild since this was my first sensitized pregnancy, but I was still very concerned about my baby possibly becoming anemic because my antibody titer was so incredibly high. So I requested plasmapheresis and IVIG treatments to hopefully delay the onset of fetal anemia and monitor for fetal anemia. And all of my requests were denied. So at 16 and a half weeks, I had a level 2 ultrasound, an in-depth anatomy scan that showed a seemingly healthy baby girl on ultrasound, no signs of fetal hydrops, and my doctors reassured me that everything was totally fine. But again, I knew, at least from what I was reading at the time, that fetal anemia doesn't always become visible on ultrasound until it's quite advanced and causing changes to the heart or causing fetal hydrops. And so finally, after continued advocacy, my doctors agreed to do an MCA Doppler scan at 17 weeks and 6 days. And to everyone's shock, it showed a very sick baby, MOM of 2.5, a small pocket of ascites accumulating in the peritoneum, and that was signs of the early stages of fetal hydrops. So it felt like my worst fears were coming true. The next morning, my daughter received an intrauterine blood transfusion. A sample of her blood showed a hematocrit of 6. They transfused 10 cc's into the cord and another 10 cc's into the peritoneum, but that blood was never absorbed because it was placed where the ascites was in that fluid. And I never felt her move again. So a little over a week later, she had full-blown fetal hydrops, an MOM over 2.7, and visible signs of heart damage. So we were just so distraught. The next day, as I was being prepped for my second IUT, we watched on ultrasound as our baby's heart slowed down and stopped. And it was the worst moment of my life. Our daughter, Lucy Dare, was stillborn just shy of 20 weeks. We were told future kel-positive babies would also die before viability because this HDFN tends to become more severe in subsequent pregnancies. So we were just completely devastated, and the grief was crushing. And I would like to share a few things that I wish my care team had known about hemolytic fetal anemia during that pregnancy with Lucy. And if they did know these things, I wish that they had managed my care with these in mind. And I do want to quickly acknowledge that I have a severe case, so this is not typical. In fact, the majority of alloimmunized pregnancies, they don't even need intervention. But it's still very important to understand that first sensitized pregnancies can be severe. KEL can be particularly aggressive because it not only destroys the red blood cells, but suppresses the bone marrow, so the baby can't compensate and make new red blood cells, especially if there's a high titer like mine. And fetal anemia can present as early as 15 weeks, but thankfully MCA Doppler scans and IUTs can also be initiated at 15 weeks by experienced specialists. Fetal hydrops is not a prerequisite for intervention. In fact, fetal anemia can actually be severe without evidence of fetal hydrops, especially in the early second trimester. And by the time fetal hydrops appears, outcomes are usually significantly worse, and you've kind of missed that sweet spot to intervene with the best chance of success. IVIG has been shown to delay the onset of fetal anemia in high-risk cases. And this is very important. With the right care, HDFN is a disease with tremendous hope, even for patients with severe disease like mine. So after Lucy's death, my husband and I explored every possible way to grow our family without facing this risk of fetal anemia again. But after a failed adoption and financial limitations, we decided to attempt another natural pregnancy. Very scary, but this time we knew what we were up against. We had a proactive plan in place. I got pregnant and we found out it was another KEL-positive girl. So I transferred care to Dr. Ken Moise in Houston, Texas. We started plasmapheresis and IVIG in the first trimester, along with weekly MCA scans starting at 15 weeks. And those weekly MCA scans were so incredibly comforting to me. Even the ones that started to get elevated, started to get close to that 1.5 cutoff, even those scans were so comforting to me because we didn't have to agonize over whether our baby was anemic or not. We knew exactly how she was doing. This time, the fetal anemia didn't develop until 24 weeks gestation. And her starting hematocrit during her first IUT was 26. So very different from Lucy's starting hematocrit of 6. And our fifth and last IUT was performed at 35 weeks. And at 38 weeks, Nora Juliet was born, healthy, chubby. She didn't need any intervention. She didn't need any phototherapy or NICU after birth, and was discharged from the hospital in my arms 2 days after birth. And we felt hope kind of slowly return to our family at that point. And today, Nora is a healthy, beautiful 9-year-old. I forgot to mention, she also did have delayed onset fetal anemia and had a couple of top-up transfusions at, I think, 4 and 5 weeks, which is very, very normal for HDFN babies, especially those who have had IUTs. And so we did it again, and then we did it again. We went on to have 2 more KEL-positive babies following the same protocol. And my son, Callum, is now a healthy 7-year-old. And our youngest baby, August, He did need 7 IUTs and had the highest titer to go against, but he was born safely at 37 weeks and is now a healthy, wild 4-year-old. And so here you can see all 4 of their HDFN courses kind of side by side. And after such a disastrous first sensitized pregnancy, we had very different outcomes with Nora and Callum in August. So what changed? The disease did not change, but our care did. And so did my understanding of HDFN and how to advocate for my babies. And while my case is rare, my story is not unique, unfortunately. This is the reality for many families, both internationally and here in the US. Throughout these years of growing my family, I was working with other alloimmunized patients, helping them through their own pregnancies, many of them facing devastating losses to fetal anemia. And many of these losses were preventable. And it became pretty evident to me then, and has been proven time and time again through our research and our work at AlloHope, that the main contributing factor to these deaths is not severity of disease, it's access to quality care. And since launching the AlloHope Foundation in 2019, we've had so many alloimmunized patients find the foundation after the death of their child to HDFN. And then with our support and proper care, they go on to have a healthy living child. And here you can see a small sampling of babies from our AlloHope community who had healthy outcomes after losing an older sibling to HDFN. And this is so beautiful and heartbreaking and compelling, because our goal is for families to have the support they need and also have access to quality care without losing a baby first. And that's at the heart of our mission at the AlloHope Foundation. And our goal is to prevent harm, fetal death, or infant death caused by maternal alloimmunization and hemolytic disease of the fetus and newborn. So we counsel affected patients, we connect them with experienced providers, we conduct patient-centered research initiatives to improve outcomes, we launch international initiatives, and we develop and share educational resources and point-of-care materials. And this is just one of our favorite resources. This chart shows critical time periods during the alloimmunized pregnancy. It's featured on our provider pocket guide and helps kind of visualize the time-sensitive care decisions that can directly affect outcomes. And we offer so many more resources, patient booklets, the Allo podcast, flowcharts, a resource-rich website, and more. So this is all to help providers and patients feel informed and supported as they go through this. And now, as I start to wrap up, I'd like to kind of shift the focus over to the maternal patient. And although, the fetus is the one at risk for anemia, the mother is also a patient. So I want to just kind of give some insight into what her experience might look like and what is important to her. The maternal instinct to protect our children is so incredibly powerful. And these patients are intensely focused on keeping their baby safe. This is what matters most. The psychosocial burden for the mother is so real. I can attest to that. Alloimmunized patients report alarmingly high rates of depression and anxiety and symptoms of PTSD, as well as feelings of guilt and self-doubt and isolation. And I think that this is very easy to overlook in the clinical setting, but it's also very easy for the mothers to overlook as well because they're so focused on their baby's safety and survival. So it's just something to be aware of. Care transitions, it goes between OB, MFM, neonatologist, pediatrician, hematologist, and then often it's the mother who's left as the only constant. And she does play an important role in continuity of care, but she desperately needs help in that role. She can't do it by herself. And patients feel more secure when they understand their condition, their baby's risks, and their provider's treatment plan. And we see that informed mothers really feel empowered and are more equipped to collaborate and advocate. And last but not least, she still needs very attentive care and support. And so what could this type of support potentially look like in the clinical setting? Here's just some ideas, and these are things that really helped me during my pregnancies and help other alloimmunized mothers. We've seen them really benefit from this type of thing. These are just some ideas, providing attentive, proactive fetal care. Of course, a lot of times this might look like referring to a more experienced specialist or collaborating with other specialists and, explaining the disease, providing educational resources, and then encouraging her to be, included, do the daily kick counts and let me know if anything is feeling off. Include her in the care decisions and discussions. And, oh, this one's so important. Give her all of her treatment options, including clinical trial opportunities. Several of those babies that we saw in that on the other slide, my favorite slide of all the beautiful babies, several of them had good outcomes because their mothers participated in a phase 2 clinical trial. And Dr. Miller will tell us more about the phase 3 trial. But just giving the mother all of her options and giving her autonomy to decide what is best for her baby and herself. And so making her feel comfortable asking questions, giving her the time to ask her questions, and sharing test results with her is so, so important. This could be like during an MCA scan, giving her the PSV, giving her the MOM. You wouldn't believe how many of us are laying there having the ultrasound with our phone in hand and we have the calculator pulled up. We're ready to punch in that PSV to get the MOM. Giving beginning and ending hematocrit during IUT is very helpful, that kind of thing. Offering warmth during an IUT. I've never felt more exposed and vulnerable than I did in my IUT procedures. And so giving the mother a warm blanket, IV sedative, and someone at her head, encouraging her, holding her hand, telling her everything's looking good, allowing her to listen to music that she chooses. These things make a huge difference for us. And of course, connecting her to mental health support and the AlloHope Foundation. So I think that's it. I just want to say thank you so much to all of you. Fetal anemia does not have to be a tragedy waiting to happen. It's a fight that we can win with education, compassion, collaboration, and timely care. And that's why we have hope. And just to all of the providers here, thank you so much for the work that you do. It means everything to families like mine. Thank you for keeping our babies safe and for helping us complete our families.
Thank you so much, Bethany, for that excellent overview and perspective. That helps us tremendously as doctors, as teams that take care of these patients. And this is something, among our team at Johns Hopkins that we're really passionate about. And so, so we just really appreciate your partnership along the way. And so I will share my slides next. And so I'm going to close it out and talk a little bit about innovations for fetal treatment for anemia. And a few disclosures, we do receive research support from Johnson & Johnson. And as you're aware, by this point, that the mechanisms of fetal anemia, essentially when we're talking about HDFN, that involves that immune response in the maternal circulation. So we have the maternal IgG that identifies that is different from the fetal RBC antigens. And so those IgGs cross over the placenta, and then they see and attach themselves onto the fetal red cells. And then what happens is it triggers them for destruction, ultimately leading to fetal anemia. And so our typical treatment that we've talked about, standard of care, is once we identify it on ultrasound by that elevated MCA peak systolic velocity, and then we move straight to fetal blood sampling and transfusion. And I love that we've brought up multiple times that fetal hydrops is not a prerequisite, and that's not what we're waiting for. As soon as we suspect fetal anemia, that we're confirmed, we're convinced that that's what's going on, we move straight to fetal blood sampling, beginning as early as that 15th week. And still, when we look within our own patient population and the cases that we see, alloimmunization and HDFN is still the leading cause of cases that we treat within our center. And when we look at how our experience is and what you can expect in our unit for about 500 cases so far, overall, we can do this quite successfully and really well. And so most of our procedures are after 20 weeks, but some of them, as you can see here, about 5% are before. Most of them we do under local anesthesia. We have a very low rate of immediate delivery or fetal demise. And notably, these are all in the setting of hydrops. So that is a terminal situation that we really want to avoid. And with very careful procedure planning and optimization, our goal is to deliver that baby at term. And so the median gestational age of delivery in our unit for all indications is a little over 36 weeks at the present time. And not only during the pregnancy, but that transition of care is also really important. And not forgetting what's required on the postnatal side is something that we pay a lot of attention to. And so this is just an example of the fetal alert card that we provide to our families, and most importantly for our patients that don't deliver here at Johns Hopkins. And it just reminds the care team who's looking after them at the time of birth what they can expect. And so one of the common things that happens is after multiple transfusions, all the blood that's in the fetal circulation is donor. So that's nice, good, invisible O-negative blood. And so we recommend that when it's safe, that delayed cord clamping can really help the transition for these babies. And it's important to remember that if they check the blood type, it will be O-negative if all the blood has been replaced. And so what invariably happens is that occasionally someone will say, oh, well, what was wrong with this baby? This baby is O-negative. And so that is one reminder we want to make sure that our teams remember. And that we know that these children are at risk for some jaundice, they may have cholestasis, and they certainly have high ferritin levels. And so when they start to develop anemia from suppression of their erythropoiesis, they don't need iron, right, to help make up that gap, which is one of the things that we can expect in a normal newborn. And then that care transition to know with the primary care pediatrician where those blood draws are going to happen, how, exactly where that can be achieved, who's going to interpret the results. And so many times we connect our families with our pediatric hematology service here at Johns Hopkins, so they have a connection when they deliver at home. And then finally, we want to ensure that we know where a child is going to have those transfusions. If it's here at Hopkins, we know how that process works, but many times we need to be sure that that workflow is established and known, so it's so much less stress for our families after delivery. And so what else can we do and can we consider? So different from our standard of care? Well, there is a lot of hope and there's a lot of work going on in this area. And so one thing that we're actively investigating is the use of nipocalimab to delay that onset of fetal anemia. How that works is this is a medication that essentially blocks that the FCN receptor, which is the transporter that moves the IgG from the maternal into the fetal circulation. And so by kind of putting that blanket over top and blocking the IgG antibody connection, then it decreases that transport of IgG across the placenta. And so we have less antibodies that can attack the fetal red cells. And the goal of that is to decrease and delay the development of HDFN. And so in the phase 2 trial, that was called the Unity trial, this was 13 patients who are at risk of early onset hemolytic disease, and they were compared to historical controls. And in this small study, what we observed is that we had more children that were born greater than 32 weeks without an IUT, and they were delivered later. In addition, compared to historical controls, there were fewer cases that required IUTs, exchange transfusions, or simple transfusions. In addition, there were no cases of high drops within this subset. And so that brings us to where we are now. And currently with that good phase 2 data, now we're in a much bigger scale, and we're in a phase 3 study called the Azalea trial. And so this is a global trial. It's taking place across multiple centers across the world. And it is randomized, placebo-controlled, and double-blinded. And so how this looks is we are screening across the world 120 participants who are at this high risk phase. So importantly, this screening has to happen in the first trimester, so super early. Once a patient is at known high risk, this is the time to get them connected if it's something they might be interested in. Because first, we have to confirm if the fetus is at risk with cell-free DNA. We have to be sure that it's safe to give this medication to the mother because it can suppress the immune system. There is a number of safety checks that we must do on the front end. And then if all safety criteria are met and it makes sense and the patient is interested, then we randomize them between 13 and 16 weeks to begin a weekly infusion of nipocalimab versus placebo, which is just saline. And so these patients are 2-to-1 randomized to nipocalimab versus placebo. And neither any of us on the study team, we don't know, the patient doesn't know, we're only going to find that out at the end. And then these patients undergo weekly fetal monitoring. And if we have concerns for fetal anemia, then we start transfusions just like we would in standard care. The primary endpoint is to identify the proportion of pregnancies that do not result in fetal demise, need transfusion, have high drops, or neonatal death. What's also unique and really important about this trial is the safety follow-up that happens for about 2 years, for up to 2 years after delivery. We're following mom for 24 weeks, and then for the fetus, of course, all those routine neonatal outcomes, but also developmental outcomes up to that 2-year point. And so this is really exciting, and we're getting that started here at Johns Hopkins. And so just to summarize who can be included and who can be considered in this trial, well, these are women between 18 and 45 years old. They must be identified, be able to complete screening, and be randomized between 13 and 16 weeks of pregnancy. They must be at high risk for HDFN and have had that in a prior pregnancy and have significant titer at critical levels and a positive fetus. For those that this trial is not appropriate for, if there's already concern for fetal anemia before randomization, then they need standard treatment and standard of care. Also, if they've had a pregnancy complication such as preeclampsia that leads to preterm birth, then that's also not a good choice. Additionally, if we've had a small baby or a patient is on systemic corticosteroids or are definitely going to have plasmapheresis or IVIG, or if they have had a history of a severe or chronic infection that we don't want to take any risk with immune suppression, then standard of care is the right path for those patients. And so we really thank you all for joining us today. To learn more about the Azalea trial, you can visit the website here, clinicaltrials.gov, and certainly reach out to our team here at Johns Hopkins. We're happy to address any questions from the group. If you want to reach us for an appointment, you can reach our nurse coordinators here at this number at 410-502-6561. Thank you so much for your attention today, and we look forward to any further discussion.
We have a couple questions. What role do monoclonal antibodies play in reducing the need for IUT?
Oh. The medication, nipocalimab, the monoclonal antibody, is that, if that's the question, then essentially this medication just blocks the IgG or the antibody transfer from the maternal circulation that is responsible for labeling the fetal blood cells and triggering the immune system to pull them out of the circulation.
Yeah, just to clarify one other thing. So if you refer to monoclonal antibodies, those would be antibodies that are targeting a specific IgG, right? When we give IVIG, that's actually not monoclonal. That's just, a non-specific tool that sort of binds the IgG, which is, what the red cell antibodies are, and makes them too large to cross the placenta. So monoclonal IVIG therapy for Rh disease, I don't think that's really available. It's just pooled. It's IgIG. I mean IVIG.
Are there any concerns about neurodevelopment outcomes with any of these new developments?
Well, I mean, in terms of the treatment, I mean, the endpoints of the nipocalimab study more. I mean, it's clear that severe fetal anemia has significant impacts on neurodevelopment in survivors. So any concern that you would have, and they come from two sources. They come from, brain hypoxemia, but they also come from preterm delivery in the setting of fetal hydrops and the neonatal complications, secondary complications, thrombocytopenia related intraventricular hemorrhages. So any, treatment neurodevelopmental impacts have to be measured against how bad the disease actually is if it is left untreated, right? That's just sort of as a backdrop, Yeah.
And within the Azalea trial, there is a developmental assessment and a specific developmental test called the Bailey score that's done at that 2-year time point, by that 2-year time point.
For high-risk pregnancies with known fetal anemia, are there any continuous monitoring technologies available?
No. I mean,
No.
continuous monitoring. Are you talking like if you there is fetal monitors that you can put on that work like an EKG, but they're not really used in this setting. I mean, you just make a surveillance plan that's sort of tailored to the risk of the fetal anemia and the deterioration so that you have a safety net, that you see the patient frequently enough.
And also, I think encouraging mothers to pay attention. They have the best intuition of all about what is the normal behavior and activity for their baby. If a mom says, my baby is not moving normally, the fetal activity has significantly decreased, I mean, that is a trigger that you just have to come and check it out. So empowering patients to listen to that and pay attention to their intuition about their baby's activity is probably the most important component for me.
Just one other comment. So there is a lot of research out of Norway about the role of fetal kick counts and instructing parents how to do that, and also educating them about the changes in fetal behavior over gestational age. And so I think in any high-risk condition, whether it's anemia or anything else, the mother is actually probably the most important continuous surveillance tool. And so understanding what's going on with the fetus and how you might perceive something, you can't really manage any high-risk pregnancy without the mother.
If I could just add one additional thing, for our babies with HDFN, we see so much success with weekly MCA Doppler scans with a critical titer or previously affected pregnancy. And so that's incredibly helpful, not spacing it out further and keeping it to weekly. That seems to be like the perfect interval to make sure that they're well monitored.
Well, I think that's especially important if it requires referral outside of your own unit, because there's also that inherent time delay of if people are at a center that isn't doing their transfusions and they're sending them somewhere else, that bakes in an additional day or two sometimes if we want to give steroids on the front end before a transfusion. So the weekly, I think, is a really helpful strategy to minimize delay.
There's one more question about how should we adjust the counseling risk stratification processes for patients with a family history of fetal anemia or high-risk genetic profiles. So I think one important opportunity is preconception counseling, so you understand what actually exactly disease is that you're dealing with and how that disease might be detected in the context of the prenatal labs, hemoglobin electrophoresis, I'm thinking about that, or the carrier screen, right? And the other thing that's important is to get as complete a record as you can about the prior fetal anemia. So if there is a blood smear available or if there's a diagnosis that has been available, then that helps you. And the other thing then is you need to determine if there's genetic testing available for an affected child, and if so, does it make sense to do that genetic testing? And if not, then you need to put a clinical monitoring, pathway in place, kind of like you would do with RH disease, that you say, like, you're going to do your MCA checks, to provide a safety net to pick up things, because there's some sort of repetition in the clinical picture, but babies may respond differently in future pregnancies, like things like spherocytosis. Some get anemic earlier on, sometimes later, but that's sort of what I spontaneously can think of.
Wonderful.
Thank you, everyone, for joining. And we will be sending out a recording of this webinar. Thank you for your time.
Thank you, everyone.
Thank you.
Thank you. Bye-bye.
Bye.